Hello, welcome dear colleagues to today's ACNAP webinar on the 2020 guidelines in adult congenital heart disease. What's in it for nurses and AHPs? I'm Dr. Jerry Lee from King's College London, and I have the absolute pleasure of being joined by Professor Philip Moons and Dr. Eva Gossings from the University of Leuven in Belgium. The aim of this webinar is to give you a better understanding of the new 2020 guidelines in adult congenital heart disease through clinical case presentations. The session is interactive, and we strongly encourage you to actively participate by sending your questions and comments at any time during the webinar through the chat. For the best learning experience, we also invite you to participate in online assessment sessions in the form of MCQs that will be submitted during the presentations. I now have great pleasure in handing over to Professor Moons for the presentation.
Thank you very much, Dr. Lee, for this introduction. Dear colleagues, we are having the privilege indeed to present to you the 2020 guidelines in adult congenital heart disease. And we will specifically address what is in them for nurses and allied health professionals. We have no conflict of interest. The 2020 ESC guidelines for the management of adult congenital heart disease have been published and presented during the last ESC conference, the virtual experience, a few weeks ago. And this was an update of the 2010 guidelines that obviously have been published a decade ago, and an update was indeed highly needed. I would like to acknowledge the entire task force and specifically the chairpersons, Professor Baumgartner and Professor De Backer. When talking about congenital heart disease, you need to know that this is the most common birth defect globally. The global birth prevalence of congenital heart disease is estimated to be 8.2 per 1,000 newborns. And there is some geographic variation. The highest birth prevalence is found in Asia, with a birth prevalence of 9.3 per 1,000. In Europe, it is estimated to be 8.1 per 1,000. Over the past decades, the treatment modalities have improved dramatically. And as a result, the life expectancy increased significantly as well. With the data that we have today, we can assume that more than 90% of children born with congenital heart disease can reach adulthood. And that is precisely the reason why an increasing number of adult congenital heart disease programs have been established. And this is also the reason why there is a need for recommendations for adult congenital heart disease care. Congenital heart disease is a collection of simple, moderate, and complex heart defects. And if you have a patient at your ward or in your outpatient clinic, and you are wondering if this patient is having a simple, moderate, or complex heart defect, have a look at the recommendations. Indeed, there is a table in the 2020 guidelines that is giving a description of different heart defects and categorize them according to these three levels of complexity. So this is already a first point where the current guidelines can be helpful for nurses and allied professionals. I just told you that the life expectancy has increased over the past decades. And as a consequence of that, congenital heart disease can be considered to be a life cycle condition. This is nicely expressed in this central illustration of the guidelines. And when you have a closer look at this central illustration, you see that across the lifespan of patients, they may encounter different problems, different complications. It's not because a child is treated during childhood that they can be considered to be cured. They remain vulnerable for developing complications throughout their life. And also psychological and quality of life issues require our attention. This webinar is comprised of three cases from different stages in the lifespan of a patient. And these three cases allows us to address particular topics that are prominent in the care for this patient group and where nurses and allied health professions can play an important role. The first case will be presented by my colleague, Dr. Eva Goossens.
So the first case that we discussed today is a 20-year-old boy, Elliot, who is actually presenting himself at the ACHD outpatient clinic after having an emergency department visit to a regional hospital a few weeks ago. The reason why he entered to the ED department was because he was experiencing progressive dyspnea for about 4 weeks. He recalled a history of heart murmur and was told to have some kind of septal defect. But besides that, he could not really recall having been undergone treatment or surgery in the past. And Elliot actually defaulted follow-up since adolescence. When looking into his physical examination, we still heard a loud murmur. His chest X-ray showed cardiomegaly, and his transthoracic echocardiography showed mildly enlarged left ventricle. Based on these observations, a diagnosis of a large complex aneurysm in the sinus of Valsalva was performed. This aneurysm further ruptured into the right ventricle right flow output tract with severe regurgitation as a result of that. Furthermore, Elliot had a dilated pulmonary artery and mild pulmonary hypertension, and still there were signs of this underlying residual VSD. The first question that we actually want to address today with this case presentation is, based on your clinical expertise or your opinion, what would be the recommended follow-up care for Elliot since he reached adulthood? So the first answer could be that since Elliot had no history of surgical interventions in the past, a checkup by a general cardiologist in a regional hospital every 1 to 2 years are recommended. Answer B would be that since Elliot has been diagnosed with a VSD, and this is considered a mild condition, a checkup every 3 to 5 years with a general cardiologist is recommended. Answer C to the question would be that as for each ACHD patient, annual visits at an ACHD care facility is recommended. And finally, answer D would be that after transfer from pediatric cardiology, Elliot should have been referred to ACHD care, and the cardiologist in that center should have determined the follow-up care.
So the result of that poll is the correct answer is D, after transfer, that he should be taken care of in the adult center. And it's good to see 82% of people got that right. Thanks, Eva.
Okay, so actually when we want to dig into the recommendations and look for indications on how to organize follow-up care, we see the following things emerging in the recommendations. As Professor Mons also explained, CHD is now considered a chronic and lifelong condition. And this means that most of our patients are actually diagnosed within a setting of pediatric cardiology, a highly specialized facility, but specialized in the care for young children. As patients grow older and engage more in adult life, the guidelines tell us that it is recommended to transfer our patients to adult care facilities because their care needs might shift over time, and such care needs are better addressed in an adult-focused and adult-centered facility. Furthermore, when we look into the details of the recommendations from the ESC, it is also very clearly stipulated that this transfer to adult care should be preceded by a developmental and counseling program, which is called a transition program. In some cases, this transition program can result into the transfer of adult care, but in some patients, even after this transfer to adult care, there is still some ongoing need for counseling, guiding, and education. So this transition program can also last a little bit longer after the transfer to adult care. When we want to address the question, where should we transfer our patients to when we are resigning them from pediatric care, we have the recommendations that can actually help us in doing this. We should actually look into the guidelines to define at which level of care our patients appropriately followed up, but also which are the recommended intervals, the time intervals between these follow-up visits. Based on the recommendations, we learned that actually all CHD patients should be seen at least once in a specialized center, because then a very comprehensive and thorough assessment of the clinical status of the patient, but also his history and his future healthcare needs, might be assessed by a specialized healthcare team. This team will then determine the level of care and also the appropriate follow-up intervals. We also learned from the recommendations that the complexity, the anatomical complexity of the heart disease itself, cannot be considered the single criterion that we use to allocate our care. We actually learned that in the recommendations, they propose a patient care stratification model, and we have a closer look into that model. The first level that is encountered in the stratification model is actually non-specialist care, which is defined as care provided by either a general cardiologist or maybe also a general practitioner, but who don't really have expertise in the care for CHD patients. Furthermore, a second level of care is defined in the recommendations. This care level is described as shared care, and as the name itself also gives an indication, this is actually care that is shared between the cardiologist, which is operating in a general hospital and not really specialized in CHD care, but in very close collaboration with specialists, ACHD specialists who are operating in a university hospital. In this shared care setting, a patient can shift along the spectrum of care in line with the needs that he has, but also the general cardiologist can consult specialists in the ACHD clinic to have some information and shared decision-making about the care process of the patient. And finally, there is also the specialized ACHD care level in our stratification model. This is care which is exclusively provided within adult congenital heart disease facilities, and where a team of specialists who are trained and have gained a lot of expertise specifically in the domain of congenital heart disease are taking care of the patient. Of course, when we transfer this allocation model to the broader perspective of European region or maybe worldwide, we see that there are some difficulties that might be encountered because of travel distances that patients might have to encounter when they want to reach out to, for example, an ACHD hospital. Therefore, the ESC guidelines now recommend that specialized care networks are actually established for a catchment area. As we see that more adults are actually emerging our healthcare system, the specialized healthcare level will most likely get saturated at one point in time. And patients will then first present themselves to general practitioners or general cardiologists when they experience acute complications such as arrhythmias, endocarditis, or signs of heart failure. The guidelines recommend us to make a liaison with ACHD centers to immediately discuss the management of these patients as our patients might be experiencing some residual or complications. But what is the team composition that is actually recommended in these specialized ACHD centers? In the guidelines, we find a very clear table of the staff requirements for specialized ACHD centers. Besides the presence of course, cardiologists, surgeons, interventional cardiologists, and anesthesiologists, we also find that there are recommendations about the number of specialized nurses, but also about other allied health professionals. They both are actually responsible for also addressing the more psychosocial, emotional, and more relational care needs that we also see in this patient population. So going back to our case of Elliot, the further management that is actually recommended for this patient is either an open heart surgery with or without the replacement of his aortic valve, or maybe a repair of that valve. And also a percutaneous closure with a device could be one of the options, which is also, of course, also a less invasive alternative. So what we learned from this case is that the development of an aneurysm is a potential late complication often encountered in patients that have a spontaneously closed VSD. This actually indicates that very regular clinical and echocardiographic surveillance is highly recommended and required in these patients. So indeed, when looking back into our MCQ, the question that we proposed in line with this case, we see indeed that the right answer would be to transfer Elliot to the ACHD center when he leaves pediatric cardiology, as a first encounter with the adult healthcare system, and ask the adult cardiologist to perform a very thorough assessment of his health status, and then determine both the level of appropriate care, but also the intervals that are recommended. So this was actually our first case, and now we move on to our second case.
This second case has to do with a woman. A woman, and her name is Kate. She is 29 years old. She was diagnosed as a child with a transposition of the great arteries. And when she was 25 days old, she underwent a rescue balloon septostomy, followed by a stenting operation at the age of 2 years. At the age of 22, she needed a balloon dilatation and stenting of the atrial baffles because of baffle stenosis. And when she was 24, she underwent cardioversion and ablation because of atrial flutter. Now she is presenting at the outpatient clinic for a planned annual visit. She is in New York Heart Association class 2. She has no chest pain, no swollen ankles, palpitations once in a while, but she had one episode of dizziness associated with fainting. Kate and her husband have discussed the possibilities to have children, and now during this outpatient visit, they are asking if that is possible. They are really expressing their child wish. So the question here is, what will be the advice for Kate and her husband? And there are 4 options. The first option is pregnancy is contraindicated because of Kate's complex heart defect. Pregnancy is contraindicated because of the high risk for recurrence of CHD in the baby. Pregnancy is not contraindicated because Kate's situation, in her situation, most pregnancies develop uncomplicated. And the 4th option is pregnancy is not contraindicated because we don't have enough data yet to think it is dangerous for the mother and the child. So please use your voting system to indicate what you think the advice for Kate and her husband should be. And I can say that this is a kind of a typical question that we have in our clinical encounters. A lot of women in their 20s, early 30s come with this kind of questions, and it is of course important that as a cardiac team we are providing the best counseling and the best advice for Kate and her husband. So the answers have been recorded. I will come to that at the end of my case presentation. So the 2020 guidelines on congenital heart disease are giving a very nice summary of what to do in case of pregnancies and how to prepare them. But there is also another document that is very relevant and highly important to guide us as clinicians. And that's the 2018 ESC guidelines for the management of cardiovascular diseases during pregnancy. These 2018 guidelines go a bit further than risk assessment for pregnancy. It also gives guidance to other reproductive issues. For instance, contraception. What can we advise to our patients regarding contraception? Well, you may be aware that the WHO some years ago has developed a so-called criterion wheel. So it is looking at different contraceptive methods and it assesses the risk for complications according to different underlying conditions. Also, some cardiovascular diseases are included in this criteria wheel. However, the 2018 ESC guidelines on pregnancy and reproductive issues go further. And for each contraceptive, they give some advice on the risk, based on the risk for complications. For instance, for combined hormonal contraceptives, it is known that they are associated with the risk for thrombosis and elevated blood pressure. This is due to the estrogens. Progestogen-only pills, injectables, and implants are associated with little effect on coagulation, blood pressure, and lipids. Hormone-containing IUDs have no effect on coagulation, blood pressure, and lipids, and copper IUDs are associated with heavier periods. So taking this together, it could be advised to go for hormone-containing IUDs because there is no effect on the coagulation, blood pressure, and lipids. However, one has to bear in mind that the implantation of an IUD is associated with a risk for vasovagal response. At the other side of the spectrum, precisely for the risk for thrombosis and elevated blood pressure, the combined hormonal contraceptives are less appropriate. These guidelines also say something about barrier methods to be avoided because it is unreliable. And tubal ligation is an option, but one has to think about the laparoscopy risk, and especially in patients with pulmonary arterial hypertension, cyanosis, and Fontan operation. What about the recurrence risk of congenital heart disease? This is included in a table in the 2020 guidelines. And for different congenital heart lesions, it is indicated what is the risk for recurrence, both for men and for women. And overall, the risk is relatively low and definitely not a reason to contraindicate a pregnancy. Let's think about our case, Kate. She had a transposition of the great arteries, and in transposition of the great arteries, the risk is known to be 2%, which is pretty low, and therefore also this should not be a contraindication in Kate's situation. Pregnancy and the risk for complications during pregnancy. Therefore, we need to look at a very nice and comprehensive table in the 2018 guidelines of the ESC. And in this table, different heart defects are categorized into the WHO classes. And this table gives an overview of the risk for cardiac events, what should be said to our patients, what advice should be given, and what is the recommended follow-up and location of delivery. So this is really a very important and very interesting table that helps us as clinicians to counsel our patients. In the current guidelines, the new 2020 guidelines, this table is included. And from this table, it is clear that only in women who are categorized in class 4, pregnancy is contraindicated because there is an extremely high risk for maternal mortality or severe morbidity. The cardiac event rate ranges from 40 to 100%. So the question here is, in which class Kate is located? And remember, Kate underwent a stenting operation, and this is an operation that results in the fact that the right ventricle is working as a systemic ventricle. Women with a systemic ventricle that is in good function or mildly impaired, they are placed in class 3. And in that situation, there is a somewhat higher risk for complications, but definitely pregnancy is not contraindicated. On the other hand, when the systemic right ventricle is moderately or severely impaired, the pregnancy is contraindicated exactly for the high risk for complications. The key question here, when we are dealing with a person such as Kate, is that we need to determine if the ventricular functioning is good enough to decide if patient Kate is in class 3 or 4. Let's make a sidestep. What is known and recommended regarding assisted reproduction? Well, superovulation is prothrombotic, and that may entail a risk. There is also a risk for ovarian hyperstimulation syndrome, and this is associated with a marked fluid shift and an even greater risk for thrombosis. It is advised to freeze all the embryos and only transfer one single embryo at a time. Women in class 4 are contraindicated for assisted reproduction just because pregnancy is contraindicated. And women in class 3 are those who are receiving anticoagulation. There is indeed a high risk for superovulation, and therefore the alternative of natural cycle IVF should be considered. So let's go back to Kate. The physical examination that was done showed that the blood pressure was 118/64. The heart rate was 66 regular. The episode of fainting that was reported was likely to be a vasovagal syncope and rather benign. This ECG showed a sinus rhythm, and on echo, only a small regurgitation of the systemic AV valve was found. Because Kate and her husband wants to have a child, we need to assess the pressures in the ventricles and in the great arteries, and especially we need to know the function of the systemic ventricle. And therefore, a diagnostic cardiac catheterization was recommended and was planned. The results of this catheterization showed that the pressures were good. The function of the systemic ventricle was also good, and therefore Kate could be categorized to WHO class 3. So let's go back to the multiple choice questions and the answers to that. The first option was pregnancy is contraindicated because Kate's complex heart defect. This was not a correct answer. People with complex heart diseases can become pregnant and are allowed to become pregnant as long as they are not in WHO class 4. The pregnancy is contraindicated because of the high risk for recurrence of the CHD in the baby. This is also not a correct answer. The recurrence risk, remember, was 2%. Let's jump to the last option. Pregnancy is not contraindicated because we don't have enough data yet to think it is dangerous for the mother and the child. Well, there is plenty of data And these data exactly supported the current guidelines, the 2020 guidelines of congenital heart disease and the 2018 guidelines on pregnancy. So we do know already a lot, and we can give good advice and good counseling to our patients. Hence, the correct answer was pregnancy is not contraindicated because in Kate's situation, most pregnancies develop uncomplicated. And if I have a look at the responses of the delegates, 30% indicated this response. So 1/3 of the delegates thought that this was the correct answer. So let's move then to the next case that Eva will present.
So our third case is about Julia, who is 47 years old and who was diagnosed with a tetralogy of Fallot combined with a pulmonary valve atresia. Her treatment history comprises a Belloc-Tausching anastomosis. She also underwent a Rosselli operation where in pulmonary position a homograft was implanted. And at the age of 26, she received a mechanical heart valve implementation in a pulmonary position. Her past trajectory, well, she did not really understand the need for a rigorous follow-up. And as she felt well over the past years, she actually discontinued her care. Furthermore, she stopped taking her anticoagulant therapy because she was feeling quite well and it was quite burdensome to remain taking this daily medication. She's a smoker with 10 pack years. She smokes about 20 cigarettes a day and has a rather sedentary lifestyle, not engaging actively in any kind of sport activities. And her BMI appears to be 36.9. So Julia actually consulted her general practitioner because she had low levels of energy. She was experiencing mood swings and also had some sleeping problems. Her GP referred her to an ACHD clinic for a further checkup, given her past history. But furthermore, the general practitioner also advised her to lose weight and to do this by, first of all, changing her diet, but also engaging quite actively in an exercise program. So now Julia comes to the outpatient clinic within the hospital and asks the clinical nurse specialist for any advice. So our next MCQ will be, what will be the advice that we can give her regarding her lifestyle? The first option is that sport participation is contraindicated in her case, since the risk for arrhythmias due to her heart disease is quite high. Answer B would be that sport participation can be recommended, but static exercises is recommended as Julia needs to prevent engaging in any physical activity that might impose a cardiac volume load. Answer C would be that at this stage, no recommendations can be made before an exercise test is performed. Answer D would be that Julia can start with light activities and increase the intensity as long as she's not experiencing any palpitations. So you can use the voting system to indicate the proper answer to this question. So this case actually relates to the management of the healthy lifestyle in our patients. And first of all, we have to take a bit of a look back into the epidemiological evolution that we have seen in this population. As depicted also in this figure by Tutorel, which was published already in 2013, we learned that the number of adults with CHD is increasing due to great achievements that we actually have encountered in the fields of pediatric cardiology, congenital surgery, but also intensive care over the past decades. So mortality has actually shifted from infant and childhood period towards adulthood. And as our patients are getting older, a high prevalence of cardiovascular risk factors is also encountered, similar to the general population. So as a consequence, the contribution of acquired morbidities, especially acquired heart disease, is actually becoming increasingly important. So to actually continue the success that we gained over the past decades in the treatment of patients with CHD, but also to further improve the outcomes of these patients, we should give more attention to the prevention, detection, and also management of acquired heart conditions and cardiovascular risk factors. So when we look into the care that we might need to provide to patients at a more advanced age, we indeed now learn, based from the numbers that we see in research, that about 90% of patients with a mild condition, 75% of patients with a moderate defect, and about 40% of patients with a complex defect actually now have the prospect of reaching the age of 60 years. But as patients reach this older or more advanced age, we see that the profile of these patients is also changing. And this translates itself to other healthcare needs. We have the inherent age risk for arrhythmias and an accelerating aging process because of the condition, the heart condition that is already present from birth. These patients are also prone to develop acquired heart disease and have an altered psychosocial profile. So we have to take all these things into account when designing the care and giving counseling to our patients. When we zoom into the risk for developing acquired heart disease, the 2020 recommendations have a very nice table in which risk-reducing strategies are recommended, specifically for patients with a cyanotic heart defect. When we apply this table with these strategies to our case of Julia, we see that an inappropriate anticoagulation, cigarette smoking, and engaging in strenuous exercises are all actually exposing activities that should be avoided by these patients because of the risk for any complications. But what about the physical exercise prescription? Because that was the question that Julia actually was asking the clinical nurse specialists. Well, then we can have a closer look into another published paper from the ESC by Butts and colleagues, where they actually advocate for an individualized and patient-tailored exercise prescription. This paper includes recommendations for regular engagement in exercises, so not for athletes. When we have a closer look into this publication, we find the proposition to use a 6-step approach. And one of the steps that is depicted in this flow chart is the performance of a cardiopulmonary exercise test. These results are used both to inform the type of exercise that can be recommended to the patient, but also the relative intensity in which the patient can engage. So what do we actually see in the 2020 recommendations regarding healthy lifestyle? Well, we see the recommendation that we can provide individualized exercise prescription, but that it should be based on a multitude of factors. We should take into account the underlying congenital heart defect and potential complications related to that condition. But we should also include the current status of the patient, both in hemodynamic terms and in electrophysiological terms. And very important, we have to assess the pre-existing fitness level of this patient. Was he or she already actively engaging in any physical activity? Or are we now initiating newly engagement in sporting? When we counsel our patients, we have to address 2 topics. We have to address the type of sports that can be engaged in, but we should also address the anticipated effort levels. At which intensity level can the patient engage in a specific type of sport? In general, dynamic exercises are recommended above static exercises because of the potential volume implications that might be engaged when patients, for example, start lifting heavy weights, which is a static exercise. Counseling and advising patients to engage in physical activities actually has a multitude of effects. We should not only counsel and advise patients to engage in sport because of the improvement in their fitness level, but we also learned from research that the psychosocial well-being, the social interaction, but also their future risk for acquired heart disease might benefit from engaging in physical activities. So reflecting back to the case of Julia, indeed, we should encourage her to participate in any physical activity, given the impact that we can see on a multitude of outcomes. But we should do this after performing a very comprehensive, individual, and tailored assessment. Based on all the data that we receive from this assessment, we can give her an individualized exercise prescription. Furthermore, in terms of the risk-reducing strategies, we should get her back on proper anticoagulation therapy. We should advise her to engage in smoking cessation, and she's not advised to participate in any strenuous physical activity. So looking back into our MCQ, we had 4 options. The first was that sport participation is totally contraindicated because the risk of arrhythmia, and this is not the case. The recommendation that she can not engage in any static exercises because this might increase a cardiac volume load is also not correct. We prefer to have dynamic exercises, but we always have to address this in terms of an intensity level, and this is also the case for static exercises. The proper answer in this MCQ would be that we actually need to perform an exercise test as part of a comprehensive assessment, like I addressed in this 6-step flowchart, before we can make any proper recommendations for her. So these were actually the 3 cases that we presented, and we hope that we have highlighted what is in the 2020 guidelines in adult congenital heart disease, both for nurses, but also for other allied health professionals.
Thank you very much. There was really interesting cases, and I think for many of us, that fact that such a high percentage of people who have congenital heart disease and make it to old age is something that probably 30 or 40 years ago was unheard of. Just with reference to the last poll, interestingly, for the number of responses we had for each of those, only 60% of responses believed that she should be doing light activities only, and only 30% actually got the correct answer about needing an exercise test beforehand. So we are now approaching the end of the webinar, and I would like to close this session by summarising the key points that hopefully you've picked up from the case presentations and that you can apply to your daily practice. So obviously one of the key things is the importance of the follow-up care and that transition to adult care. And I think it became quite evident that some patients get lost in the system and then only present when they become quite symptomatic. So that's definitely one of the key messages. And also, as explained, that there was the patient stratification care model. So not every patient needs the same level of care, and obviously being able to apply that and ensure the patient is getting the correct care is important. There's also, especially as we mentioned with a case study of Kate, the importance of contraception in women and managing the pregnancy and ensuring that if there are contraindications or if there's a high-risk pregnancy, that the woman and her partner are fully aware of that, and education is really key there. There's also, like most conditions with the acquired heart disease, again, even though these patients have got the adult congenital heart disease, they're still at risk of the risk factors and the conditions that other people are. So that lifestyle risk factor and encouraging the physical activity is really important, but the patient must have their exercise test in the first instance. So I'd like to take this opportunity to thank you all for joining us. I'd really like to thank sincerely Professor Philip Moons and Dr. Eva Gorsigs for their presentations. And to learn more about these new congenital heart disease guidelines, you can download them and feel free to click on the link that is currently displayed on the interactive timeline. And you'll be able to watch this webinar on demand on the ESC website. Thank you once again for joining us today.